Welcome to Roadmap to Residency. Today we are diving into acute kidney injury, one of the highest yield topics for Step 2 clinical knowledge. This video is not about teaching you the entire concept from scratch. Instead, we are focusing on test-taking strategies and question stem patterns you will actually see on exam day. I highly recommend reviewing your first aid and UWorld explanations alongside this video to solidify the foundational knowledge. Let us get started. Here are our learning objectives for today. First, we will master the prerenal, intrarenal, and postrenal framework. This classification is the key to quickly categorizing any acute kidney injury questions stem you encounter. Second, we will learn to interpret urine studies like fractional excretion of sodium and urine osmolality. These values are board favorites, and knowing how to use them will help you eliminate wrong answers. Third, we will apply test-taking strategies to management questions and learn when dialysis is indicated. Let us build these skills together. This is the most fundamental framework for approaching any acute kidney injury question. Prerenal means before the kidney. The kidney itself is fine, but it is not getting enough blood flow. Think of hypovolemia, heart failure, or medications that reduce perfusion. The key concept here is that the kidney is trying to compensate by holding on to sodium and water. Intrarenal means the kidney tissue itself is damaged. Acute tubular necrosis is the most common cause you will see on boards. The tubules are damaged and cannot concentrate urine properly. Postrenal means obstruction downstream, like from benign prostatic hyperplasia or kidney stones. Always remember, when you see a question stem, your first job is to categorize it into one of these three buckets. Now let us talk about urine studies, your secret weapon on test day. For prerenal causes, remember this pattern: fractional excretion of sodium less than 1%, blood urea nitrogen to creatinine ratio greater than 20:1, urine osmolality greater than 500, and urine sodium less than 20. The kidney is holding on to everything because it senses poor perfusion. For intrarenal causes like acute tubular necrosis, the pattern flips: fractional excretion of sodium greater than 2%, blood urea nitrogen to creatinine ratio less than 15:1, urine osmolality less than 350, and urine sodium greater than 40. The damaged tubules cannot reabsorb sodium. Memorize these patterns. They will directly help you answer questions. Let us work through our first case. Pay attention to the clinical clues. This 68-year-old man is post-operative, meaning blood loss is likely. He has hypertension and tachycardia, which are signs of hypovolemia, and he has oliguria, or decreased urine output. What is the most likely cause of his acute kidney injury? Let us break this down step by step. First, spot the clues. Post-operative setting plus hypertension plus tachycardia equals hypovolemia until proven otherwise. Second, calculate the blood urea nitrogen to creatinine ratio. 42 divided by 2.4 gives us about 17.5. This is close to the classic 20:1 ratio seen in prerenal disease. Third, apply your test strategy. Whenever you see hypertension plus oliguria plus elevated blood urea nitrogen to creatinine ratio, think prerenal first. The correct answer is prerenal azotemia from hypovolemia. The next step in management would be intravenous fluid resuscitation. See how quickly we got to the answer using our framework? Here is our second case. A 55-year-old woman with diabetes receives gentamicin for pneumonia. Her creatinine rises on day 4. The urine shows muddy brown granular casts. Her fractional excretion of sodium is 3%. What is the most likely diagnosis? Let us walk through this case. First, identify the toxin. Aminoglycosides like gentamicin are classic nephrotoxins. Other high-yield toxins to know include contrast dye, amphotericin B, and cisplatin. The fact that she has diabetes increases her susceptibility to nephrotoxicity. Second, recognize the cast. Muddy brown granular casts are pathognomonic for acute tubular necrosis. This finding appears in nearly every acute tubular necrosis question on boards. The fractional excretion of sodium of 3% confirms we are dealing with intrinsic kidney injury, not prerenal. The correct answer is acute tubular necrosis from aminoglycoside toxicity. Now let us solidify your understanding of fractional excretion of sodium interpretation. Less than 1% suggests prerenal or early obstruction. Greater than 2% suggests intrarenal, usually acute tubular necrosis. But here is an important exception. Fractional excretion of sodium can be misleadingly low in contrast nephropathy, myoglobinuria, and early sepsis, even though these are intrinsic causes. Board questions love testing this exception. Also, when your patient is on diuretics, fractional excretion of sodium becomes unreliable. Instead, use fractional excretion of urea. Less than 35% suggests prerenal in patients on diuretics. Here is case 3. A 72-year-old man with benign prostatic hyperplasia history presents with decreased urine output and lower abdominal discomfort. You can palpate a distended bladder. His creatinine has risen significantly. What is the most appropriate next step in management? This case is straightforward once you recognize the pattern. Elderly man plus benign prostatic hyperplasia history plus palpable bladder equals outlet obstruction until proven otherwise. Whenever you see a distended bladder on exam, think postrenal. The correct answer is to place a Foley catheter. This is both diagnostic and therapeutic. It will relieve the obstruction and allow you to measure output. Be aware of post-obstructive diuresis, where the patient may have massive urine output after relief. If the diagnosis is unclear, renal ultrasound will show hydronephrosis. Case 4 tests your knowledge of dialysis indications. This 45-year-old woman has potassium of 7.2 despite medical management, pulmonary edema unresponsive to diuretics, altered mental status, and electrocardiogram changes including peaked T waves and widened QRS. What is the most appropriate next step? For dialysis indications, memorize AEIOU. A is for acidosis refractory to bicarbonate therapy. E is for electrolyte emergency, especially hyperkalemia with electrocardiogram changes. I is for ingestion of dialyzable toxins like lithium, methanol, or ethylene glycol. O is for overload of fluid that is refractory to diuretics. U is for uremic symptoms like encephalopathy or pericarditis. In this case, our patient has E for refractory hyperkalemia with electrocardiogram changes, O for pulmonary edema refractory to diuretics, and U for uremic encephalopathy. When a question presents multiple AEIOU criteria together, dialysis is almost always the answer. The correct answer is emergent hemodialysis. Here is our final case. A 60-year-old man with heart failure and chronic kidney disease has his lisinopril dose increased. 1 week later, his creatinine rises and his potassium is elevated. What is the mechanism of his acute kidney injury? This question tests your understanding of medication-induced kidney injury. Angiotensin-converting enzyme inhibitors like lisinopril dilate the efferent arteriole. This decreases the pressure gradient needed for glomerular filtration and causes a functional prerenal state. The hyperkalemia is a clue because these medications reduce aldosterone secretion. Know the key associations. Angiotensin-converting enzyme inhibitors and angiotensin receptor blockers cause efferent arteriolar dilation. Non-steroidal anti-inflammatory drugs cause afferent arteriolar constriction. Both reduce glomerular filtration rate, but by different mechanisms. The correct answer is decreased efferent arteriolar resistance. Management is to hold the medication and monitor for recovery. Thank you so much for watching. If you found this video helpful, please like and subscribe to support our channel. For personalized tutoring and residency advising, check out our expert team at roadmaptoresidency.com. Good luck on your boards.